doesn't it?
Hey, good evening to Facebook, Instagram, Twitter, TikTok, and to all of our social media family. Thank you guys for stepping in with us on this evening. What time is it? It is time for Couch Conversations with the Doctors. It is Monday night, and I physically just walked in my house and pulled my hat off and my coat to sit down for us to have Couch Conversations with the Doctors. We are so happy that you guys are here with us on this evening. So we want to remind you to start your watch parties and share. Again, remember to share because it is time for Couch Conversations with the Doctors. I see I have some of our lovely co-hosts and panelists here with us on tonight. We're going to go around really quickly and do our introductions as we do all the time. I want to say hey to everybody that is here. I'm going to start with my coworker, Dr. Douglas Graham. Doug, if you can please introduce yourself.
Hi. I'm a physician who worked in the western suburbs for about 30 years. I retired, and about a year ago, I went to Washington, D.C. to work in Representative Davis's office as a congressional fellow. So I will try and answer your questions if I can. I'm really delighted to be here. Thank you.
Thank you so much, Doug. And know that Doug is in the sun while we're all thawing out from the snow and treading through water, but he is in the hot sun. I'm going to go around a little bit more, and I could swear that I actually viewed the world-renowned urologist that's here with us on this evening. And is this not? Oh, it's Dr. Terry Mason. All right, Dr. Mason, if you can introduce yourself to everyone that's here.
Hi, everybody. I'm Dr. Terry Mason, retired urologist after practicing for 26 years and been doing a bunch of other public health stuff around. So I'm just glad to be here and be of service.
Wonderful, Dr. Mason. Wonderful. And I think that's the weight loss guru that we have here, the family medicine doc that is A-OK, the one who can get everything done in one moment. However, his real passion is to be on Iron Chef. I think that's Dr. Tony Hampton. Go right ahead, Dr. Hampton.
Good evening, everybody. Totally excited to be here as usual. Always happy to share what I know. We kind of learn as we go. So as we learn, we'll share. And as we share, we'll learn, So it's really a beautiful thing. And I really appreciate you guys being engaged. And we look forward to answering whatever questions you guys have tonight.
Wonderful. I want to say hey to Martha Puckett, who has checked in with us. Hey to Kathleen Jackson. And hey, Audrey J. Cox. Remember to share, and start your watch parties. Thank you guys so much. I can tell that someone just flew in and landed their jet, and I believe that is Dr. Pete. Dr. Pete?
Hey, guys. Good afternoon. I'm excited to be here. I'm the Director of Medical Support Services at Near North. And hopefully we can answer some questions and clarify some myths and bad rumors.
I think that's a given. I think that's really necessary to do. So on tonight, as you have started your watch party, we're just going to get into those questions. We're going to go ahead on and get started. Dr. Pete, that first question that we have, I don't want to chop it up and beat up what they're asking about. So it says, what is, pronounce it?
Monoclonal antibodies.
All right, infusion treatments. And does it really work to treat COVID-19? So what is that? And does it work?
Yeah, so recently the FDA did an emergency use approval for monoclonal antibodies, which basically the antibodies are the part of your immune system that helps to fight off diseases. And so there were clinical trials that showed that patients who received the monoclonal antibodies, which is an IV infusion, usually runs between 16 minutes to an hour. It's a one-time infusion. If the patients can get it as an outpatient, it can reduce the hospitalizations and deaths for patients who are from COVID. There are a few caveats. One is, it's primarily for people who are 12 years of age and older. It's for patients who have had symptoms for 10 days or less. It's for patients who have had who are basically mild to moderate symptoms and who are at a high risk for getting sick. So there's specific people that we give this medication to. And just like most new therapy, we're not entirely clear on what all the benefits and risks are. But for one thing's for sure, if someone is at risk for hospitalization and death, we can deal with whatever might happen 4 months from now. But tonight you can die. Okay. And so the idea is get these patients treated who are at risk for that, who are at risk for the severe infection, and you can save a life. I don't know if anybody else has anything to comment about that.
I would just add that there is a website called The Fight Is In Us.org. And it's a website that if people have more questions about this, they can go and look at it. And what this comes from is that much like donating blood, you can actually, those people who have had COVID can donate plasma. And it's done very much the same way as donating blood. In fact, there's very little difference except that when you donate your blood, the plasma is part of it. And the other part is the red cells and other things. So there is, and I would encourage you, if you want to learn more about it, go to thefightwithinus.org so that you can see and understand if you're interested in donating it, because these things have to come from people. It's not something that they make as a drug. They have to come from other people. And it's like a blood transfusion, only it's the non-blood part of your blood. So that would be the only thing I would add to that.
So,
thank you. Was somebody about to say something?
yeah, I was going to say something about this, Nikki, and that these monoclonal antibodies work kind of like Patriot missile defenses. They go into your system and they attach onto the virus, and they keep it from attaching onto you. Or another kind of these antibodies will attach onto the chemicals that are released by the virus and keep those chemicals from causing more inflammation. So these are very, very tailored and specific treatments. They're very accurate and precise, and they really represent very, very real sophisticated advances in medicine. Yeah. So just think of them like, and they're temporary. They get in your system, they do their job, they get out, and they have very little chance of changing you biologically, psychologically, or any other way.
Right.
So Kim Alexander Jackson says, good question. And Curtis Jones is here and he says, hello to everyone. So Dr. Mason, I think that's a great segue into our second question, because I think you really answered it, or if it corresponds with the first one, which was how does convalescent plasma work? And is it a good treatment? I am post-COVID and was just wondering if I should donate.
I think you should go to the website, talk to the people, and then make your decision based on the information that you get. And if you choose to donate, that's a good thing. Because the only way you would get this convalescent plasma with these antibodies is from people. So we've got to, that'd be a great thing if you choose to do that.
And we're in this community, Nikki. We're in a community, and we really are here to serve each other. Very few people when they're on their deathbed is, talking about the nice car they used to drive or the big house they lived in. They talk about, what difference that we make in the lives of others. So if we can imagine, it's really a small price to pay. You donate some blood, which, in this case would be the plasma, the liquid part, like Dr. Mason said. And you can literally prevent somebody who may have otherwise ended up in a hospital from having their disease progress to that point. So it's really a gift, and it's an easy gift. You don't have to spend no money. It's just really a little of your time. And so we just have to, what we haven't done well in this country is come up with a process to make it easy for people to make these types of choices, because you have to kind of make the decision at the right time for people. So I just think that we could do better there, but absolutely. I think the vaccines that's where the money's at. But in terms of other ways to mitigate the risk when people have been exposed, perfect examples, whether it's the, antibodies or the plasma, this is just a way to help those who have been exposed, because we're not going to keep everybody from being exposed. So we want to have other ways to mitigate the risk.
Wonderful. Great. So, Dolores Wild says, good evening, everyone. And Sandale Scott says, hello to everyone. I want to say to the person who asked me, thank you for saying that my neck and face look smaller. Thank you very much for that. I'm losing weight. That is thanks to keto, so thank you so much. And try it. I fell in love with my air fryer. I'm not going to tell Dr. Mason that I air fry some chicken. I'm not going to tell him that. But I am in love with my air fryer. So Kathleen Johnson says, is there any truth to O blood types are less likely to have an adverse effect from COVID?
Wow.
I think that's a wonderful question since I have
we've done I've done research on the blood type diets and all those types of things, and you see some studies that show that there's this correlation, and then you see other studies that don't. Now, the way, just so people understand, when you do research, you when you hear terms like correlation, association, that does not mean causation. So you can do a study that says that if you are, a really good father, your chances of getting prostate cancer will be reduced. I mean, they do. I mean, literally, they have studies that show these associations that are just so random. So until we see double-blind studies that show causation, that these are direct, things, I think it's too early for us to make blanket statements about blood type. So is it possible? I think it's absolutely possible. But I don't think that we're at a point in this process where, that's why everybody kind of paused, because we have not seen the data to support these types of beliefs. Now, I'll be honest, I haven't spent a ton of time doing this research on this particular topic, but every time I look it up, I can't find anything that's of great substance.
Yeah, and I think Dr. Hampton, to your point, I think that's why we do this show, is because so many people, we hear things and we want to believe that there's something else that's out there. And while
we lost him for a minute.
Yeah, it's a little frozen.
I tried to do that to him when I was in medical school with him, but he wouldn't stop talking.
Is it work? You can never freeze him?
I tried
and now
to freeze
it's working?
Yeah.
It's the basketball moves.
There we go.
Okay.
Okay, I'm back. Yeah.
Go right ahead.
Yeah, the bottom line is,
I'll tell you what he said about you later.
Well, don't worry. I'll let Dr. Hampton get away with it. Yeah, we just don't have any studies, and so you can say what you want, and we can, and we want to believe certain things, but until we have that hardcore data, then it's hard for us to say something definitively.
Okay, well, Linda Johnson says good evening, and she laughed too, because she heard what was said. So, wonderful, wonderful, wonderful. Want to share, our next question says, why is it so difficult to develop an antibiotic treatment for this viral illness?
Well, I'll just comment real quick. So I think most people are aware that antibiotics are really about bacteria, and antivirals are really about viruses. So the structures of bacteria are completely different than the structures for the virus. So virus and bacteria, so that's the first thing we have to understand. And so when you create an antibiotic, it's simply going to target bacteria, and it really doesn't do much. That's why they train us in medical school not to, if we have a viral infection, which is what a common cold is, when we give antibiotics, which patients will insist they need, we're really not doing them any service. We're just exposing them to the risk for infection. So the question becomes, we don't want to create resistance. And that's why they train us to think that way. They want us to, because if we keep giving the antibiotics to a patient with infections that don't even require it, then the bacteria will essentially get accustomed to it, and they actually can adapt to it. They do this via mutations, just like when you think about coronavirus, it mutates. Well, the bacteria mutates too. And if you keep exposing it, eventually it'll figure it out. Another thing that happens is just like in life, it's like survival of the fittest, right? So over time, the bacteria that survives tends to be the bacteria that's the strongest as well. So what we want to do is limit overexposure to the wrong infection, to the wrong antibiotic, and therefore give us a chance to have something that'll work down the road. And the other thing to keep in mind is, I don't know. I don't even remember. I mean, they just don't make new antibiotics every day. I mean, it's actually shocking. And that's true of pain medicine too. We've been using the same old hydrocodone for it feels like decades. So and it's like it's hard to come up with new treatments. So what we don't want to do is take the treatment that we know works. We don't say penicillin, we say give me some Cillin, right? I got patients that will insist, Doc, I know what you're saying, but I just need you to give me some Cillin, I'll be all right. That is some tussin. So what we want to do is we want to be responsible citizens and stewards of our resources, and make sure that we're actually being scientific, and not like, if you can't come to me and if I'm not being a scientist, I'm not like the cat down the road. I should be able to come to you as a scientist and give you science, and then hopefully that'll reassure you that the decision that we make together is a scientific decision, and it's the right decision.
Yeah, and Dr. Hampton, I'll just add to that, that how we know is, one is the years of training that we've had, but also that bacteria and viruses behave in a certain way. And so when we are asking you questions, we're trying to, delineate what kind of behavior does this infection most resemble, a bacterial infection or a viral infection. Now, obviously, the most accurate way is to get a culture. If we get a culture, and let's say you come in with a sore throat, and we think you might have strep pharyngitis, where we do a culture to see if the bacteria actually shows up. If the bacteria is not there, then we know that it's most likely a virus. So then that's when Dr. Hampton has to break that news to you that you're not going to get no Cillin. You're going to get some warm fluids and some Tylenol, and everything's going to be all right. In the words of, was it Bob Marley?
And then the comedian is going to say, you're going to learn today.
You're going to learn today.
No Cillin for you.
And by the way, our health system, Dr. Pete's health system, the health system that our retired colleagues, Dr. Graham and Dr. Mason, worked in, they ding us. They actually review our charts. And if they see us giving away antibiotics to a person that has the wrong diagnosis, they actually consider that, poor medical care. So it's not just us trying to do our due diligence. They literally kind of monitor that, because the insurance companies and nobody else wants you to be getting inappropriate treatment, because there's things that can happen to you, side effects that are detrimental to you. And if a person ends up in a hospital because of a poor decision like that, that doesn't look very good. So we have to kind of, again, be responsible, and we have to all kind of play a role in this.
So you mean if I'm at home and I got the same cough I had 2 years ago, I can't just tell you, give me another Z-Pack, because that's what you gave me last time? You physically need me to come in and see you? Okay.
And it's unlikely that you have a bacterial or viral infection that long. So but what Dr. Pete is saying is that we have the kind of a training that kind of cues us there's something else going on. And so we need to, so what you want is a doc or advanced practice clinician who's a detective, and they can kind of figure things out for you. So that way you don't, because all you'll do is get that treatment and you'll be coughing a month later regardless.
Okay. All right, you still gonna send me to see that ear, eyes, nose, and throat person, huh? I'm just trying. Virginia Knight is here, and she says, "Hello, beautiful people. How are you today? Fine, and thank you." So I love that. And Virginia, I'm going to be calling you when this goes off. Linda Johnson once again says, "Hello." The next question says, I'm still having memory problems. Is there an idea how long this will go on? I believe, well, I know for a fact that this young lady had COVID, and she asked a question about it before. So I think she's trying to ask, how long do we think this will last with the COVID?
Yeah, we're still learning about patients with long haul COVID infection, and it's only about 10% of people who have this. And and one of the problems is that people might have is this fogginess and memory loss. We don't know. The bottom line is we don't know how long this might last, and there's no definitive treatments for this as well. So there's ongoing research that's happening. So I would definitely recommend that she has her primary care to refer her to a neurologist, a brain specialist.
And I want to just emphasize, we don't have double blind, we don't have the kind of studies we have for the vaccine that we would need to figure out all of these COVID related negative consequences. Think about this. Like, you got somebody, I have patients who are 2, 3, 4, 5, 6 months out, and they're still having the side effects of the infection. Now imagine if this doesn't go away. Imagine for a moment if this person who asked that question continues to have mental fog for the remainder of their lives. And that's why we continue to emphasize the vaccine, because we're not having those types of problems with the vaccine. And I also want to celebrate the fact that we have a new vaccine out, and I'm sure we're all aware of that. But I just want to put that on the table, because you'll hear things about the new vaccine. Well, it's only 66% effective, and people find reasons not to be excited. I'm going to tell you, I'm very excited, because this vaccine is only one shot. It tends to have less side effects, this Johnson & Johnson vaccine. You'll get more access to it because you can just put it in the refrigerator and keep it in there for weeks. And it's just another opportunity for us to get more people protected. The most important data point that I heard, though, and I'm sure you guys have heard it too, nobody in the studies, nobody ended up in the hospital. Nobody ended up on a ventilator with who got vaccinated. And at the end of the day, that's what we're afraid of. So I think that if you have access to a vaccine, Pfizer, Moderna, or Johnson & Johnson, and hopefully AstraZeneca will follow, I would just get the first vaccine you have access to. I think that's the key. And keep in mind, when they did this new vaccine, a lot of the studies were done in, I think it was in Africa or India. I can't remember which, but the bottom line is that they were having the variant versions of coronavirus already in their environment. So now you have a vaccine that's working, but maybe it was at 66% because it was in an environment where those mutations that we talked about had already occurred. So we have to keep that in mind as well. So I think part of what we're trying to do is just provide perspective. But my biggest message to you is that vaccine is fine. And most vaccines that are on the market for the flu, et cetera, they're probably in the 60 to 75% effective range anyway. I mean, so I think that this is exactly where it should be. The Pfizer and Moderna were just unique in that the technology was different and more advanced.
I'm just excited that we have another level of keeping people out of the hospital and from being sick. Yes. I'm excited over that. Linda Johnson says, I was listening to the news and they stated the Johnson vaccine may cause blood clots.
Yeah. And I hadn't heard that yet, but I don't know if you heard it, Dr. Graham, yet, but I will say this, all the vaccines have side effects, right? The question is in how many people, so we need more data before we really give an educated response to that. But I'll tell you, penicillin can cause problems. The flu vaccine can cause problems. Every time you take, I mean, I want everybody listening to just go online and just type in ibuprofen. I mean, it'll say it can cause heart disease. I mean, all of these things have the potential, but the benefit outweigh the risk in this particular case with, it's a slam dunk. So let's see what happens. But I doubt that what you heard was the issue. I can guarantee you one thing that can cause a clot, and everybody knows on the panel, coronavirus. Coronavirus is a coagulopathy nightmare. We use that type of language. It means that it can clot you everywhere. So that's the clot I'm worried about.
Okay. Audrey Jaycock said, because I just thought you were going to pull out your booklet again or your phone or whatever it was.
I thought about it, trust me.
That gave us all those side effects to that Viagra. I was just I don't know. Maybe you need to pull that up. Maybe you need to pull that up and share it. You might need to share that again. Audrey Jaycock said Johnson & Johnson's mutation had occurred in Africa and potentially will ward against the new strain in America.
That sounds like positive, right?
Yeah, it does.
Yeah.
Woo, said Virginia Knight. I hope I did it. Woo, all right. So we are moving on here. Our next question says, does COVID-19 exacerbate a cancer diagnosis?
Interesting question.
Yeah. I
think we have to have more information about the question, because if you're talking about a brand new diagnosis versus one that's been treated and is in remission,
right,
those are two really big different questions. And the real problem is that this virus really affects your immune system, which is really needed to fight the cancer. So I'm pretty sure that if we talk to a cancer doctor, they'd want all their patients getting a vaccine just to keep their immune systems from being affected by the virus. I mean, that'd be my speculation.
Yeah. It's the cancer can affect your immune system because cancer is a high energy utilizer. So your body is just constantly trying to deal with this cancer. So now you have your cancer affecting your immune system, which predisposes you to COVID. And then if you're being treated with COVID, one of the mainstays of treatment is steroids and things like that. So that can then make the cancer your immune system being suppressed, and you need your immune system to fight the cancer. So bottom line is that if you have cancer, you need to be more cautious. If you get COVID and you have cancer, they're going to have to keep their eyes on you. And, they may even pause treatment if you're being treated just to kind of allow you to recover. So there's a lot of factors. It's very complex, but at the end of the day, you just want to have the strongest immune system possible. So if you're a cancer patient, it's really important that the things that we preach on this show about lifestyle and just, again, if you don't get enough sleep, your immune system's not going to be good. If you're stressed out, your immune system's not going to be good. If you're not really following the treatment guidelines that are being given to you, then you put yourself behind the 8 ball. So what you want to do is mitigate all those different risks to the degree possible.
I don't know who's that. I keep hearing somebody or
something.
I don't know what that is, where it's coming from, but somebody needs to mute their phone.
Well, maybe we can just start. It was
but I would say this to what you were saying.
Yeah, it may have been Nikki.
Yeah, one of the things I was saying to what you would say to what you said is that, in addition, cancer therapy actually, and you may have said it, but actually some of the cancer therapy actually further weakens the immune system because they're giving you very toxic drugs to try and kill the cancer, which kills other things too.
That's right.
And I wanted to correct something. When we were talking about antibodies before, I spoke about the antibodies from plasma, but the monoclonal antibodies are done and made a different way. So I wanted to make sure that I corrected that and did not leave somebody with the wrong information.
Yeah.
So I just want to make sure that was made clear.
Yeah.
We have another question. The other question says, can you guys share your thoughts on the increase in addiction to illegal substances with this COVID-19 and share some resources? I have a child struggling and it's gotten worse. I think I think, with the COVID.
Yeah. What comes to mind, Brother Pete, on this one is I've referred a lot of people to behavioral health resources during this pandemic. And as any of us could imagine, your life is already challenging because you've had to kind of resort to that. And I don't blame anybody for having a struggle, but you're already struggling because you had to resort to substances to kind of treat your your depression, your anxiety, maybe the supervisor not right, maybe the marriage is not right, whatever it is. And then you throw a pandemic on top of it. Wow. So I always tell patients, if there's ever a time you're going to struggle, it's now. Yeah. So the first thing is like, be okay with the struggle. It's real. And then, so I would anticipate that you're going to have a higher suicide rate. I would anticipate you're going to have a higher drug use rate. I would anticipate all these things would happen. So I think the key is most health systems have a team of people that you can refer your patients to who are expert at dealing with these crisis moments. We normally have Dr. Cersei on the line. She's our expert in behavioral health. And so if Dr. Jasmine was here, she'd probably add a whole nother level of, information related to this topic. But the other part is, if you have somebody in your life who is struggling and they're struggling to make a decision to go get help, there are plenty of resources. Even I would even start online. I mean, I would go listen to Eric Thomas or something, just a positive brother. And I would just put Eric Thomas, you wouldn't, he may not have anything that's specific substance, but you may want to say Eric Thomas, depression, anxiety, whatever. And listen to a brother like that literally inspire you, because sometimes if you feed that mind all of that good stuff, it'll counter all the negative, and it'll allow that person who's struggling to put life in perspective. And when you start to look at the world from a different lens, it may give you just enough inspiration or just enough perspective to maybe you can reconsider, should I pick up this alcohol bottle today? Maybe you'll say, man, if I pick this alcohol bottle today, I won't be able to be the father that God intended me to be. So what'll happen is it'll provide perspective. But most people who have substance issues need professional help. So I would start with your current doctor, your current organization, and then that's where I would start. Any other thoughts, guys?
Yeah, the other thing is, Tony, thanks for that. So because we have a MAT program at Near North, I'm personally seeing my patients who are struggling, and right now we're in the middle of a opioid epidemic on top of the COVID pandemic.
That's right.
And when I talk to patients, it's really interesting because just the same way that COVID has disrupted our normal distributions of like products and food and other things, it's disrupted the drug industry. Yeah. And so now more heroin is coming to the United States with varying degrees of fentanyl in it. So it's like the worst. It's like like a big pot of gumbo. It's like the worst possible scenario is happening. So now, on top of having these varying degrees of non-heroin sources on top of the drug, because from what I understand, it used to be that the heroin would come to our shores, and whatever the drug kingpin here would put a certain amount of fentanyl on the heroin. But now it's already coming with the fentanyl on it. We don't know how much of that heroin is fentanyl or how much of it is pure heroin. So then what happens is the guy that you normally go and get your heroin from, who's there every Thursday at 4 p.m., is no longer there. So now when that person does show up, that person trying to get as much drugs as they can. So there's so much of that. Now, you add that on top of the fact that many of the previous resources, because of COVID, like the inpatient centers, the You know, we can't keep people in those places anymore. So now that's disrupted. So that's what I'm saying. Like, this is the worst possible scenarios. So places like our program, we're having to do what we call harm reduction. We're having to give patients longer prescriptions for their Suboxone and for their methadone. Why? Because we know this guy may not be able to get here tomorrow. He may not be able to get here next week. So we have to get. So we're trying to mitigate the amount of challenges that this person is going to have, recognizing the fact that our ideal goal is to have this guy not to go and snort heroin, because that next snort he takes might be his last one.
Mm-hmm.
You know, Peter, and to your point, I think sometimes, and I'm going to be a bit clinical right here now, because we don't know. First of all, these drugs are used in their varying forms, particularly fentanyl, legally every single day.
Right.
Every single day. The fentanyl is used in the surgical areas every day. And it is a drug that's at least 10, I don't remember exactly the multiplier in terms of potency related to morphine. But what happens with these drugs, all of these kinds of narcotics, whether it's the heroin or the drug, the synthetic, that's even more potent than heroin, which is fentanyl, they depress your respiratory centers. And the way people die from these drugs is they don't breathe. And that's the problem. And so what we have to remember is that these drugs we use in surgery, when I was in surgery, we use them all the time. But the difference was when we used it, we put a tube down somebody's throat and put them on a machine so we could breathe for them while they were asleep. The problem with this is once people get it, it could be so quick that they fall asleep. And if they're not, and the respiratory center is so depressed that they stop breathing. And if they don't get somebody to reverse this drug very quickly, that's what kills them, whether it's a lot of morphine or even less of this fentanyl-laced stuff. So,
Dr. Mason,
so dangerous.
It's 50 to 100 times more potent than morphine.
Yeah.
Yeah.
Wow.
Yeah, and so one of the things that we do too is we make sure that every patient has a prescription for Narcan, which is the antidote, if you will. That if you notice somebody that's not breathing and they're sort of stuck, that you would hit them with the Narcan, and it's an intramuscular. Well, they have intranasal Narcans and they have intramuscular Narcans. And you can hit them with that Narcan and it can reverse. But the problem is, because of the potency and because of how strong that fentanyl is, that you still have to notify 911 because the Narcan doesn't last that long. And so, the fentanyl, will likely last longer than that Narcan will.
It's just so sad.
Yeah.
And then I've seen situations where, when you go out with folks that deal with this sort of thing, that people actually wake up when you give them the Narcan, they're sometimes not happy with you.
Oh, yeah. Oh, yeah.
They're not happy with you because what you've done and what it's cost them to get to where they are. But we still have to do the right thing.
Yeah.
We still have to inform people of the risk that they're taking, no matter what it feels like. And I'm just saying that these drugs are so immediately addictive.
Yeah.
It's not the person's fault. The drug is so addictive that once you're addicted to stuff, it's hard, Pete. It's hard.
Yeah.
Talk to many, many people. It's not like, they can make a decision tomorrow not to do this anymore.
Yeah.
They really can't do it. And so that's why what you guys do at Near North and getting people into therapy and getting them on something that they could use to help them is so very important.
Yeah. And just so that people are clear, Dr. Mason and Dr. Hampton had mentioned Dr. Searcy, because the trifecta is not just the pharmacotherapy from the methadone and Suboxone, but then it's the addiction counseling, which is done by a CADC person. and then it's the behavioral health. So you're approaching the addiction from three different angles. One is the addictive behavior. One is the underlying conditions that patients find themselves in, that found themselves addicted to whatever, alcohol, heroin, cocaine. And many of the patients, to your point, have polysubstance use. So they're not only struggling with like a heroin addiction, but they also use cocaine. They also use alcohol. So it is challenging. So that's why, it's important that we cover all those areas, because again, even once you free them from the chemical addiction, then there's still like the behavior. Like I'm still mentally addicted to my addiction,
Ooh, I have to review Virginia Night again. Woo, that's a lot. But it's great that we have these outstanding resources out here to be able to help our community through these issues that they're having. Melanie Winston says good word. Sean Kennedy says good evening. I logged in and the only word I heard was alcohol. Laugh out loud. Well, Sean, let me tell you, this is couch conversations with the doctors, not cocktails and conversations. So know that comes on at 10 p.m., not at this time right now. So you can join my friend at 10 p.m. who will be having cocktails and conversations. Martha says, wow, Audrey Jaycox kind of clears up maybe a typo that she had in her last post. Linda Johnson says, so true. So true. Linda Johnson also says, dual and also some in MISA clients. MISA? What's that acronym? Does anybody know what that acronym stands for? MISA?
I don't.
The MISA clients. Maybe that's like a dual program with mentally. I'm going to look that up and find out. I'm going to look it up, and Sean Kennedy is now laughing. So I know he is paying attention and being coherent to what we are talking about. Our next question says, can depression cause you to lose your sex drive? And if so, how can I tell my husband?
Wow. Well, depression can do a number of things. And losing sex drive is only one of many things that depression can be a part of. And the key is, as we've just been talking about, is you've got to get help. You can't try to fight your own way out of this. You've got to get to professionals that can help you understand what is going on, use pharmacotherapy, medications if necessary. But still, even with the pharmacotherapy, you need people to help you with. Now, I remember with a lot of the men that I used to see who were depressed because they couldn't have erections. And unfortunately, early on in the medical situation, we used to tell men that they couldn't have erection because it was all in their head. That it was not, that's before, and I go back a long way, 25, 30 years before there was even a Viagra. And so many guys ended up getting unjustified testosterone injections and all kinds of stuff, trying to see what they could do. But depression actually gets aggravated by the erectile dysfunction. So when a man can't function, and you got to, for man, that's really, it gets to the core of what he considers or what is considered manhood. We can't do that. When we wrote the book, Making Love Again, it was one of the things that women were struggling with because the men would have these depressive situations and oftentimes would lash out at their partners and do all kinds of different things. So it's real. So the main thing they could do is really help the guy get help. And a lot of times the medications may not be enough. And so that's why I would recommend that they see a urologist that specializes in erectile dysfunction, because many times, I did over 200 penile implants in my time because that is the logical extension of the last thing that's available. But it is, I can tell you that I saw many men, and I had many men sit in my office and cry. Okay? Because this is serious. And I know people don't think it's that serious, but we make sex such an important part of our life, and being able to perform such a value proposition that when that's not there anymore, it really, really, really can go to the core of the man. So we had to get guys, even once they were able to perform again, albeit perhaps with some medication or surgery, we still had to get them back into the idea that just because the penis was hard didn't mean that the relationship was repaired. So you had to work on repairing the relationship, and you took away that one source of anxiety, but you had to really reintroduce them to intimacy after that.
I like that, because when I was a resident doctor at West Suburban Hospital in Oak Park, I actually did a rotation at Loyola, and they had a very famous sex therapist. And
Dr. Demina Renshaw.
Amen. That's right. I learned a lot from her, and I learned a lot from Dr. Ruth Westheimer, if she's still around. I spent many nights, on the radio listening to this old lady talk about sex. And I think it's important that we learn these things, and we need to be comfortable talking about it. And I think, Nikki, your question was, can depression cause you to lose your sex drive? And obviously the answer is yes, it can. But you not talking about it will cause you to lose your relationship. So I think it's important that it's easier to talk about it and say there's a problem. It's not about you. I have this issue. The couch conversation Doc said is related. So let's get some help from that. And guess what? This is the part that's a little scary. The medication can cause you to lose your sex drive. So the antidepressants can actually affect your sex drive. So who'd have thought, right? So it's very complex, and we want to make sure that we take advantage of getting people who are experts to help us. And there are medicines. I'm into homeopathic. So St. John's wort, that's old school, but that herb that actually works for a lot of people without the risk of affecting your sex drive. So I think we need to think bigger, broader. Exercise will actually improve your sex drive. So we need to, you don't want to be around me after having been to the gym. I'm not trying to be funny, but when you go to the gym, it actually lifts that drive up.
Yeah.
So those really natural things that you can do are better than just waiting for a pill.
The other thing is getting to the root cause. And so I think, like I was listening to Nikki Giovanni and James Baldwin had this interesting sort of dialogue with each other. And it was obviously an old film, just to give you the Cliff Note version is that they were talking about where each one of them comes from, from a Black man experiencing racism and discrimination, and then a Black woman experiencing sexism and racism, and then having to come together in a relationship. And what does that mean? What does that look like? And I think so much of us is riddled with sort of traumas that has happened to us, right? As individuals, and then as people in this country. And then some kind of way we act like none of that stuff happened. And, we act like it didn't happen. Like we act like all our past didn't happen. Like Uncle so-and-so didn't do something to the little nieces and all. We act like this stuff didn't happen, and we need to acknowledge what happened. And I know it's easier said than done, but you got to get help. So that the Viagra pill, while it might take care of an acute, right now I got to perform, but I'm still dealing with why I don't feel like a complete man. I'm still dealing with that, and I say me, but I'm saying as a community, and we just gotta get to the root cause of what is going on with us, and who knows. At the end of it, we might become a better person, a more whole person, so that, to Dr. Mason's point, that I'm actually a better person to have a relationship with, and not just for somebody to have sex with.
Nikki, I'm having mental fog because it looks like Danny Davidson got young all of a sudden.
So first of all, before I cut you for trying to call my boss old, because I'm gonna cut you.
I'm not touching it.
He said he got younger, so I'm gonna cut you.
I'm touching it. I'm not touching it. I don't know where you was going with that, Dr. Hampton.
But I will like to say that he is the youngest member that is on Ways and Means, which is most important. And that's what's important to us. You know, I want to introduce everybody to my coworker, Lavelle Brown.
Hello, everybody.
The congressman is voting and literally running down the hall to try to get here because he did not want to miss this.
Yes.
His Monday nights is this is his baby. This is his brainchild. This is his Monday night. So he texted me to tell me Lavelle is going to sign on. Lavelle signed on, and he is sitting in the chair while the congressman is running from one building there. And literally, he walks so fast, so it's like a run. Am I right or wrong, Dr. Mason?
Yes.
He walks so you cannot keep up with him. I do not walk with the congressman because he walks off and leaves you. And then he will reach back and grab you and drag you because you just walk too slow for him. So he's literally coming. So he loves his Monday nights. You know, Melanie Winston says, I love Dr. Ruth. Virginia Knight says, well spoken. Linda Johnson says, good teaching. Dr. Mason, she says, good teaching, Dr. Mason. Linda Johnson says, yes, teach us, Dr. P. And then Martha says, very information. And there's a couple things that I got out of you guys teaching. Not just the teaching of what you were saying, but the fact that in those teachings, you also begin to remove stigmas of having therapy to just show how important it is just to have those conversations. So I love it, and I know our audience is loving it because not just we have some that are writing in there. We're getting tons of text messages that saying, thank you, Dr. Mason, and this is wonderful. I understand different things now. So this is really great that you are sharing, and the way you shared it, but you guys are so eloquent all the time. And you're also very touching all the time in every aspect, even though we're not using hands. So this is wonderful. You know, our next question says HDL and LDL. Which one is the good?
Nikki, before the next question, before we go,
go ahead, Dr. Hampton, go right ahead.
I just wanted to add something to what Dr. Hampton was saying. I took Dr. Demeanor Renshaw's course, and I took it with Dr. Karen Taylor Crawford, who was the co-author of the book. And we had, and maybe one day we have a show that really talks about our unaddressed childhood traumas. Mm-hmm. And they've never been addressed. We take them into adulthood, and then we take them into a marriage or a relationship. And now you may have two people who have unaddressed childhood traumas that don't understand why stuff doesn't work. And so it wasn't until I learned how to take these sexual histories with Dr. Renshaw and other people that we really, because I'm gonna tell you, our people have been traumatized. Mm-hmm. There's no way you look at our history and don't come out with some horrific kinds of trauma. So it at least bears an opportunity. I mean, I sat there when you start doing these questions, asking some of these questions, and these guys start boo-hooing, you know, and then you do them separate. You do some with the wives, and sometimes then after you do it, you bring them together. But I'm just telling you, there is so much pain and so much unrealistic expectation that we expect from ourselves being damaged without ever having an opportunity for any kind of repair.
Yeah.
Wow. Now, how do I ask a question behind that, Doctor? Ask no question.
That's cool, because I did that work for over 25 years, and I sat in those rooms. And when a man talks to you about their erectile dysfunction, it doesn't get any barer than that. That or maybe an addiction, no puns intended, but it really is. And I just want to give space to let the listeners know that we are taking this very, very seriously and not lightly. And maybe one day we'll talk about this.
Yeah, yeah. And I think Dr. Mason, to your point, that even though a lot of us, and Tony knows that as a primary care doctor, I mean, we're almost like therapists too, you know. And so on top of helping and with the immediate concern of the erectile dysfunction and maybe writing for, you know, whatever, Levitra, Cialis or whatever, but the reality is we got to tackle what's going on between you and your mate. What is being discussed there? Why do you feel like you can't talk to them? And it's deep. I mean, it gets deep in that exam room, and you like, I don't have the time to go over all of this.
I know.
Because it really does open up like Pandora's box.
Yep. I know what you mean, Pete. That's why I used to run 2 hours late all the time.
Yeah.
So Audrey Jaycock says, excellent topic for future Monday conversation.
Yeah.
So they're asking for a whole Monday just about this. So I think that's great. I think it's really great. Karen says, evening all. Bonnie says, good information. Good information. This is great information. I don't know how I'm supposed to ask a question after Dr. Mason. I think at this time, once again, church, we need to pass the collection plate. He just took us there once again. He has taken us there once again. Our next question says, HDL and LDL, which one is good cholesterol and why? And as a 50-plus-year-old woman, which one should I work on making sure is in the right space?
Yeah.
Well, the good cholesterol, I'll start. The good cholesterol is the HDL. The bad cholesterol is the LDL. The HDL, typically, you know, there are foods that are that promote more HDL production, and it's like salmon. A lot of your oily fish will do a salmon. And your LDL, you want to try to avoid. That's from like red meat and things of that nature. I don't know. You want to ask something else, Doc?
Yeah, I think one thing that I've learned that we're having a shift in the paradigm as it relates to cholesterol. So if you think about it, you know, one thing that I try to teach is metabolic disease, metabolic syndrome. So if you look at the parameters for metabolic disease, we talk about HDL, we talk about the triglycerides, and we also talk about your belly size and your blood pressure, as well as your blood sugar. Those are the 5 things. The question is, why are we not talking about total cholesterol and LDL, which is that's because they found that those are not as critical. Now, the LDL has large and small particles, and we're now measuring the particle size, small being bad, large being good. But what I would tell anybody listening who's really trying to understand, there's a couple of things you should think about doing. If you really want to know your risk, number one, you should get a coronary artery calcium score test. So I know in our health system, it's a $49 test. They look to see if you have plaques in your arteries. That's number one. Number two, when your doctor measures your cholesterol, what you want to do is look at ratios. So you want to look at a ratio like your LDL divided by your HDL. So that's the bad divided by the good. That should be less than 3. Then you can do your other ratio, which is your triglycerides divided by your HDL. That should be less than 2. And then there's a test called the apolipoprotein B, which is a better measure of inflammation and your risk for heart disease. So I guess what I'm getting at is some docs are pretty up to date on that. Other docs are not. But at the end of the day, there are different things to measure. If you look at your total cholesterol, it actually has good and bad in it. So that doesn't really tell you anything of value. You want to be able to break it down. But the best test for heart disease is that coronary artery, in terms of a screening test that's cheap, that you pay, and they don't pay for it through insurance. Just make that investment. And if that number is looking good, if you have a low score like a 0 or a 10, then you can be reassured that you're okay. And what that brother Pete said about the things you can do, I totally agree. Exercise helps the HDL as well. And also reducing that starch and sugar in your diet also helps as well. So those are the things I would recommend.
Awesome.
Hey,
Simply
hey,
awesome.
hey, Dr. Mason, and Dr. Hampton, Dr. Doug, can you guys tell me the effects of the HIIT work, the high intensity interval training? Does that have a more impact on your HDL than, let's say, regular resistance training or regular cardio? Do you know?
I would say that it's more efficient. So if you do high intensity interval training or HIIT, that's with two T's, high intensity. It's actually two I's. Yeah, So what you want to do is recognize that we're all busy. There are nights when I leave this couch conversation and I'll exercise. Tonight is not a night for that, but imagine me spending, let's just say from 8:15 to 9:45. So if I do high intensity interval training type exercises where I do something quick and then I take a little break and then I do it really quick, I can actually get more bang for the buck. And I have seen I've seen some data that would suggest that you do get the type of improvement. Like when I wrote my my first, actually the book I'm working on now with obesity, I actually have a section where I talk about exercise, and I do recommend that as one of the top options. But I say it with caution because for my elderly patients, that may not be a good option for them. Right. So you have to be able to do those types of things. I remember back in the day when Walter Payton used to run up the little hills, and, everybody can't do what Walter Payton did. So you have to do something that's within your, that's reasonable for you. But I do think that because time is so valuable, I think it's a great option.
I would just say that I would just add to what's been said is that I don't want people to think that you can out exercise a bad diet.
Mhm.
You cannot
Preach, Bishop. Preach, Bishop.
You can't out exercise a bad diet. Now, exercise is great, but exercise does other things. Exercise is good for cardiac conditioning, helping those sorts of things. But you just cannot eat a bunch of pizzas and think that you're going to go do whatever kind of exercise and you're going to be fine. That does not work. And I think Dr. Hampton and I would both agree that we need to really be mindful of the fact that it's very difficult, very, very difficult. And even for people who do high intensity training all the time, it's still very difficult. So there's no substitute for still eating well.
So we got a ton of laughs after that statement of eating a bunch of pizzas. Can't eat a bunch of pizzas and then work out. Tons of laughs behind that one. The next question says, what is the proper consistency of your stool?
I'm only going to unmute myself to say that's Dr. Mason's question.
You're the internist. You and Peter, the internist. What I can say is, if you're sitting on the toilet pushing so hard that your eyeball's about to pop out, that stool is too hard. Okay, it's too hard. It should be more like toothpaste coming out of a tube. Okay, that's the way the stool should be. And if it's not that way, you either have a combination of things going on, usually not enough fluid in the diet and not enough soluble fiber in the diet. Okay, so you really need to be thinking about that. And I'll just leave it at that because I don't want to get any further into it, but I could.
We'll go right ahead.
No. We do because I see we're already at the end of time, or we're already over time. So we can pause that and pick it up.
Okay.
Puns intended.
Pete, you unmuted because you had something to say.
No, just I agreeing with my brothers that we're I think as a country we're chronically constipated. One, because we don't get enough green leafy vegetables.
Tony, you got your wrist again, Dr. Hampton.
Okay.
I caught you this time. I caught you. Yeah, no, I was just saying that we're chronically constipated and chronically dehydrated. So drink more water and eat more green leafy vegetables.
Yeah.
Okay. More water, more green leafy vegetables, and you'll stay Dr. Mason's best friend as long as you're eating green leafy vegetables Very important. Why is it so hard for women to lose belly fat?
You know what? I'm going to ask Tony to talk about that, but I'm going to tell you this right now. You do not spot lose fat. Okay? You cannot just lose fat in one area. You either lose it everywhere or you lose it nowhere for the most part. But spot reduction doesn't work.
No. And I agree 100%. I actually made a video, how to lose belly fat on YouTube. So anybody can search my name in that. And one of the things I say in that video, Dr. Mason, is like, listen, this is bigger than, this is not about doing sit-ups. As you and I would agree, it's your diet, number one. And it is true that women have a slower metabolic rate. When I did my obesity training, they said women have a slower metabolic rate. That's not fair, but that's what it is. So if your metabolism is slower, that's going to make you have a problem with weight. They also, some are genetically set to have a weight that our body tries to keep us at. And that's when your genes come in. And sometimes women have a set point that's at a weight that's higher than they would like it to be. And that's when your genes have something to do with that. Clearly, women don't have as much muscle. So and that's why they get upset at their husband, because he decides to lose weight and 6 months later, he's looking like a bodybuilder and she's still struggling. That's because we have more muscle. And when you have muscle, it's going to keep burning fat over and over again, even when you're not doing anything. And then sometimes women have the responsibility of cooking, and you got to taste that good stuff to make sure it's okay. So by the time you look up, you didn't have a whole meal tasting the food, you know. But there's many factors. I think it's hormonal. And at the end of the day, I think women sometimes struggle more. So that doesn't mean they can't achieve the goal. It just means that they have to work a little harder. But I definitely recommend people check out that video, because it gives you some basics and some tips on how to do that without, taking too much time during this conversation.
When you get the opportunity, Dr. Hampton, can you drop that link in the comments? That would be great. Elise Buford says, and if you are menopausal, that's an additional challenge. And that was just what Dr. Hampton was talking about. It could be hormonal. So yeah, it can be a challenge. It definitely can. I know my coworker there, Lavelle Brown, cooks for me sometimes when I'm in DC. And for those of you, you know that we work late, because in DC it's 9 o'clock and they are still in the office. Lavelle cooks and he tastes all the food, and then we had these weight loss challenges. And Lavelle and Yule tend to lose weight much faster than the women in the office. Lavelle and Caleb, they tend to lose weight much faster than us, so we no longer go into weight loss challenges with them because it is so unfair. Kathleen Jackson asked a question, and we're going to take her question last, and that is, how do you know when you are dehydrated?
Most of the time, you'll be thirsty way before you get totally dehydrated.
Yeah.
Could you get ashy, or could your skin get like very ashy, or?
Yeah, well, there is some signs of clinical dehydration, like your skin. There's something called skin tinting, where like you can pinch your skin and it doesn't go immediately back. There are other, like, we can look at your inside your mouth to tell if you're dehydrated. A lot of people, they drink soda pops and coffee all day just to stay awake, and then as a result of that, they're like further making themselves dehydrated. So yeah, there's definitely signs, and I tell you, just how you feel. When you're feeling very lethargic, you'd be surprised how, I don't know if you remember, when we were in training as a resident, like we would have patients that would come to the ER and they would look like they were really, really sick. And then we would give them a bag of IV fluids, and you'd open back up the curtain and you wouldn't even know that this person was like, this person, all they really needed, well, yeah, they might have been infected with a bacteria or whatever, pneumonia, but they really needed that IV fluids, And so, yeah, the fluids are very important. So definitely, get your water on.
Nothing replaces water but water.
Yep.
No.
Nothing replaces water but water. People say, I don't like water. Well, you know what? You don't like 60% of what your body's made of.
That's right.
So, Dr. Mason, I know earlier you asked what was going on. Come on. So, my house has been invaded by Trinitarians. Hi.
How
I've been
you
invaded
doing?
by your church member, Deacon Davina Ward. How are you?
Hello. I'm doing great. I'm doing
Hello,
great.
everyone. She's making me starve and eat gummy bears. Somebody has to eat them.
And bacon.
So, as we always do on Monday nights, it's that time again, and I know you guys hate to hear it, but it's that time again. So we're just going to go around the table really quickly, and we're going to ask everyone to share a final thought so Lavelle gets to thinking. Douglas Graham, what would you like to leave with everyone until next Monday? So what's your until next Monday?
I remember what Dr. Mason said last week, and I just want to support him in what he said. And we are making progress. We have new vaccines. We're getting better at distributing. We're getting better at tracking. We are going to get over this. We're not where we want to be, but we're going to get there.
Dr. Terry Mason, your until next Monday?
Well, I got my first shot at Provident this past week of Pfizer vaccine. So that I'm glad to finally get that done. And I just want everybody to know that you're the main steward of your health. Don't put it in anybody else's hands. What you do or don't do has more to do with how well you live than anything else.
Lavelle Brown, if you could say something to all the listeners that are here to encourage them until next Monday, what would that statement be?
Continue to exercise. Put that on top, make that a priority to exercise and eat lots of green vegetables.
Wonderful. Wonderful. Dr. Tony Hampton, your until next Monday.
I echo the positive words of Dr. Graham. We are in a pretty good spot now. We have an administration that's making a stronger effort to do the things that are necessary. With the approval of additional vaccines, we really have an opportunity to vaccinate more people. More people are becoming more comfortable. And for those who don't, we will certainly still be your brothers and your sisters. We just want to encourage those who will to do it and to, get it done as soon as possible. So I'm excited, and I'm ready to go to a movie theater. I'm ready to gather and do the things. I'm ready to get on the plane. I'm ready. So I just look forward to doing those things which I miss. And I'm just hoping that everybody does their part so that we can work as a community to get to a healthier place.
Dr. P, you're until next Monday.
Until next Monday, guys, take care of yourselves. And I mean, when I say take care of yourself, I mean your mental, spiritual space. Because from there, a lot of things can happen. And one is you can make good decisions for your health, rather it's, going to get the vaccine or exercising or eating well, not over consuming food, not having food to be a crutch for what's really going on with you. And yeah, if you need to see a therapist, call your primary care and go see a therapist, man. It's time to heal.
If Dr. Jasmine was here tonight, her last words would be mindfulness. It would be mindfulness. All of you who have asked me, inbox me and ask a question via email. Am I going to put photos up? Did I get my vaccine yet? I've been pushing everybody to get their vaccines. I'm done. I got both of my vaccines. I've been done since mid-February. I just forgot to put my photos up. So I will definitely put those up so you can see that Nikki got both of her vaccines and I am all done. Also want to say this past Saturday, our office actually aided in making sure that almost 1,000 with 984 constituents were vaccinated with their first dose, and the second dose will be administered on the 17th of March. We will also be sponsoring some of these events again. We had a wonderful press conference about it just as well. Media was there, and it ran the entire weekend to encourage those to make sure you get your vaccine. Doesn't matter which one you got, you're going to still be okay. Dr. Mason and Dr. Hampton and Pete, I believe they all got Pfizer. I got Moderna. We are all great, and we are here to let you know that don't believe the hype, in other words. Remember to mask up. So as we leave you on this evening, join us here next Monday, same that time, same that channel. And as we always say, remember to do these following things. Remember to wash your hands, wash them really good. Get in here. Don't forget at 20 seconds, sing that happy birthday song. It's so important. Remember to social distance. Stretch your arms out. And if you're touching someone or if someone is touching you, know that you're just a little bit too close. And most importantly, I want you to make sure that you wear your face covering. Make sure that you have those masks over your nose and mouth. That's over your nose and mouth, not just over the mouth or over the nose, over your nose and mouth. The droplets are what it gets you. And remember to join us here. We want to see you again. Thank you guys so much for joining us. And Dr. Hampton, I got some Band-Aids for you. Everyone have a good evening. Thank you so much.